Hi, everyone. Welcome to Fluid and Electrolytes, a topic that we just get every course, I suppose. So I just want to go through this handout with you. I'm not going to read every word from the handout, but there certainly is a lot of information. And as many times as we've gone over fluid and electrolytes, it's just easy content to forget. So I do want you to do a little bit of review with you because there's some very important information you're going to want to know. All right, so let's just start with fluid. We'll talk about total body water. And males, total body water is about 60%, females about 50%. So we know that the majority of our body is fluid, and women are a little bit less because there's more fat. Elderly also have less water because of lack of muscle and increased fat. Okay, so they have less water. That becomes significant, so they're more prone to dehydration. Let's just take a look at this once again, the extracellular fluid and the intracellular fluid. So as far as total body water, a third of it is in extracellular fluid and 2/3 of it is in intracellular fluid. So the majority of our water right here is intracellularly. That's where the majority of it is, 2/3 of it. 1/3 of it is extracellular, which is divided into our blood, plasma volume, and then interstitial fluid, spaces around our cells. And that's what's considered extracellular fluid. So this is important information, and this is a little demonstration when we give fluids. So it's kind of an eye-opener if you don't know this. It's kind of interesting. So I'm going to talk about two different types of fluids, isotonic fluid and hypotonic fluid. So when we're talking about isotonic fluid, we're talking about fluid that has the same tonicity as blood, and one of the most common ones is 0.9% normal saline. So if we give somebody isotonic fluid, which is the most common IV fluid, right, that makes sense. We want it to have the same tonicity of the blood, and we would give hypo or hypertonic in different situations, which we'll talk about. If we give a liter of 0.9 normal saline, 1 liter to the extracellular fluid, 250 cc's, 25% of it goes to the intravascular space. So let's take a look at that again. We give the isotonic fluid, it goes into the extracellular fluid. Only 25% of it is going inside the vessels in the vascular space. 75% of it, 750 milliliters, is going into the interstitial space. So we give these patients these IV fluids, 0.9 normal saline, and they just blow up, they just get a ton of fluid volume overload. So they have a lot of water on board, but it's not necessarily all going inside the plasma. Kind of interesting, kind of helpful to know. That's why these patients go up to the floors and we have to give them a bunch of Lasix to get the extra water off. Now let's say we give somebody a hypotonic fluid, okay? We want to give somebody a hypotonic fluid because not only do we want it to go extracellularly, but the reason we give hypotonic fluid is to get inside those cells, right? Inside the cell, somebody has cellular dehydration. So if we want to fill up vessels, and this is important, a couple of you guys have missed this on some case studies, if you want to fill up vessels, so giving somebody IV fluid and who's hemodynamically unstable, blood pressure's down, they have to get isotonic fluid because you can see that all goes into the extracellular space. Or hypotonic, 0.45 normal saline, when we talk about somebody with DKA, certainly they're severely dehydrated, so we want to give them some a hypotonic fluid. But if they have some low blood pressure, their hemodynamics are unstable, we have to give them isotonic to fill up their vascular space. So hypotonic IV solution, one being half normal saline, less than isotonic, low tonicity, 1 liter of 0.45% normal saline. 333 go into the extracellular fluid, right? And 83 to the intravascular space. So the majority of it is not staying in the veins. It's going into intracellular fluid. 2/3 will go into the intracellular fluid. And then out of this, only 83 cc's, 1/12 of this hypotonic fluid stays in the vascular space. So that's certainly used to fill up the cells for somebody who's got severe dehydration. Fluid intake, we know that it can be ingested fluids, 1,300 milliliters, water and foods about 1 liter, and oxidation about 300 milliliters a day. Fluid loss, there's sensible fluid loss, insensible, and abnormal fluid loss. Make sure you know the difference between them. Any of these would be examples of abnormal fluid loss. Somebody's bleeding, burns, when any time the skin is interfered with, burns or wounds. We have a rapid fluid loss. There's a lot of fluid that are inside the cells, right? There's a lot of fluid that's inside the cells right here. So when the cells get damaged, this water comes flowing out and they have a fluid volume deficit because they have abnormal fluid loss. Let's talk about the different IV fluids. IV fluids, which we call crystalloids. So crystalloids are, I think of it as crystal clear. They're the IV fluids, where colloids are something that has more substance in it, like the albumin, the dextrin, those types of things. So crystalloids are IV fluids. Keep in mind, we just talked about isotonic fluids. The goal is to increase intravascular volume and therefore increase blood pressure. That's the goal. And here's 2 IV solutions you must know that are isotonic. A lot of times the patient's in maybe like a trauma center, ER, we give them lactated ringers. It has more stuff in it. It's still isotonic, but it has potassium in it, has lactate in it, it has some calcium in it, it has sodium in it, it has other electrolytes. Whereas 0.9% saline, it's just sodium and chloride. Regardless of what's in them, they're both isotonic, and that's important for you guys to know. Hypotonic would be low, hypo, going inside the cell. Half of the 0.9 normal saline, which is 0.45%, is going to go into the cells. So it's best. This is the best IV fluid for somebody with dehydration. But what if they're severely dehydrated and their blood pressure is down? Isotonic is going to be the fluid of choice until we get them hemodynamically stable. So goal is to increase the intravascular volume and to correct a free water deficit, best given for dehydration. D5W, once the dextrose is eaten up by the body, because our body uses dextrose for energy, the only thing that's left is pure water. So D5W is considered, it's isotonic in the bag, but when it gets into the body, it's considered a hypotonic fluid. Glucose is rapidly taken up by the cells, leaving only the free water. Best if replacing free water deficit or hypoglycemia. So you should know those. Hypertonic fluid, the only one you need to know is the 3% saline. So if 0.9% is isotonic, very obvious that 3% is hypertonic. Used only for severe symptomatic hyponatremia, which we're going to talk about coming up when we talk about sodium, and cerebral edema. Okay, those are 2 main reasons that we use hypertonic. Pretty much that's it. And we'll talk a little bit about using that coming up. This next section just talks about osmotically active substances. And when we talk about them, we're talking about proteins and glucose. Plasma protein holds on to fluid in the vascular space. There are several types of plasma proteins, but the most abundant is albumin, and this is the one that we measure right here. If a patient's badly burned, malnourished, they have a decreased protein intake, we measure that by measuring their albumins, or has disease where the liver is not making adequate amounts of albumin, so the liver makes albumin. So any of these situations, they can have hypoalbuminemia. Adequate albumin is needed to hold on to the fluids in the vessels. If they don't have this protein in their vessels, water just leaks out through the capillaries. It doesn't stay in the vessels. Fluid may leak out of the vessels into the tissues, can cause shock. So sometimes you see people there with a huge fluid volume overload. We give them a ton of fluid, but it's just seeping out of the veins. It's not even staying into the vessels. And these patients look as if they have a fluid volume excess because they're so swollen from fluid accumulation in the tissues and interstitial spaces. But it's not in the intravascular space. So we've got to have plasma proteins that are osmotically active that pulls and keeps fluid in the vessels. Glucose is also osmotically active and can draw water out of the ICF into the ECF. Think about somebody with hyperglycemia. When the blood sugar is very high, as in a diabetic, the blood has too many glucose particles compared to the water in the vascular space. This causes particle-induced diuresis, which is a symptom of hyperglycemia, sometimes called osmotic diuresis. The kidneys monitor the blood for fluid, electrolyte, and particle imbalance. When the kidneys sense the increased number of glucose particles, they want to help the blood rid the excess, so polyuria occurs as the kidneys are trying to excrete that excess sugar. The kidneys continue to filter the blood to decrease the serum glucose, resulting in fluid loss from the vascular space. That's why these people thirsty peeing, thirsty peeing, thirsty peeing. If this goes on long enough, hypovolemia and shock can result. And we know that these patients with DKA and HNC come in and they're severely dehydrated. The next section is hormones, and hormones help keep our electrolytes within normal range. Insulin moves potassium from the blood to the inside of the cell, causing the serum potassium to drop. So we know before we start insulin drips on patients, we got to make sure that their potassium is in a fairly normal range, or they are going to become extremely hypokalemic and get into even more trouble cardiac-wise. So insulin, very important concept to know, moves potassium inside the cell. So when we give patients insulin, their serum potassium is going to drop. That's why you'll see that's one of the treatments for somebody who has hyperkalemia. We give them some insulin, some dextrose. It pulls that dextrose and pulls the potassium with it inside the cell. Parathyroid hormone versus calcitonin, just to review for that. When there is hypocalcemia, the parathyroid recognizes it and secretes parathyroid hormone. And when we have an increased parathyroid hormone, it increases calcium from the bone. So it tells the bone, get rid of some of the calcium and put it in the blood. It decreases the calcium excretion in the kidneys, tells the kidneys, stop peeing off kidney. And it increases the phosphorus excretion in the urine, because as phosphorus goes up, calcium goes down. So know what the parathyroid gland and parathyroid hormone do. And the opposite is calcitonin. When the thyroid hormone or thyroid recognizes that there's an increased calcium, calcitonin is secreted for an increased calcium. And the calcitonin says to the bone, don't release any more calcium. We have enough calcium in the blood right now. We've talked a lot about aldosterone, which is this whole cascade is initiated when there is a decrease in blood pressure and blood volume. When we have a decrease in blood volume, automatically the kidneys do not get the perfusion that they need, right? Because the kidneys are the renal arteries, you have to take a turn. Kidneys are the first to take a beating. Once the kidneys recognize that there's a decreased blood volume, we start the cascade. Renin, angiotensin 1, which gets converted into angiotensin 2, which is a potent vasoconstrictor. Very helpful when we have low blood pressure with a low blood volume. Angiotensin 2 now initiates an increased aldosterone. If you see aldosterone, you think sodium retention. Aldosterone increases, so our kidneys say, hey, we're going to hold on to sodium. And because aldosterone is secreted and sodium is retained, you must know that aldosterone causes a decrease in potassium. Very important concept. So when we're blocking aldosterone with aldosterone blockers like ACE inhibitors and ARBs, this changes, right? We get a decrease in sodium and an increase in potassium. So super important, very basic concept here. Once the sodium starts to become retained by the kidneys, hence water will be retained and we get an increased blood pressure because of this cycle. Antidiuretic hormone, we say antidiuretic hormone, you think water, not sodium. So basically increased osmolarity or a decreased blood volume activates in the hypothalamus, and we get an increase of antidiuretic hormone from the posterior pituitary, which increases free water reabsorption in the collecting tubules, which increase circulating volume and decreases sodium concentration. Why? It's increasing water, okay? Antidiuretic hormone directly relates to water, not sodium. Couple concepts when administering insulin, especially IV insulin. Watch the serum potassium level can drop, leading to life-threatening arrhythmias. The only kind of insulin that can be given IV is regular insulin, period. Anytime serum calcium increases, the phosphorus level decreases, and vice versa. You should know everything that I went over, and all of this is testable. All this is extremely applicable in the clinical setting, and it would be something that you would definitely want to know for certification. Thank you.